Knees can be painful because of a number of reasons, including injury, wear and tear, or arthritis. If you've had an injury at a younger age, then that might contribute to the knee wearing out prematurely or part of it wearing out. The arthritis we commonly associate with a knee that is wearing out prematurely is often referred to as degenerative arthritis. Osteoarthritis is a little bit different, but it looks and acts about the same as degenerative arthritis. But osteoarthritis can affect multiple joints. And then less commonly, we see inflammatory arthritis like rheumatoid arthritis. Treatment of osteoarthritis of the knee ranges from very minor treatments to more aggressive treatments. Sometimes a mildly arthritic knee may occasionally be supported with a brace, and that can be helpful. Over-the-counter anti-inflammatory drugs may be helpful in many patients. When not, we can move to stronger, more prescription-grade medications. There are a variety of medications that we inject into the knee joint. They range from corticosteroid injections to a category of drugs referred to as viscosupplementation. Osteoarthritic knees are painful, and if they're painful to the degree that the pain is not relieved by more conservative measures, and if the knee has progressed to a point where the surfaces have failed, that's when we entertain surgery to replace the joint, replace the surfaces, or replace all or part of the knee. Knee resurfacing is where one surgically replaces a damaged surface in part of the knee as opposed to replacing the entire joint. Knee resurfacing can be limited to just one compartment or two compartments, or in some cases all three compartments in the joint. In resurfacing a knee, sometimes it is done biologically and sometimes it is done with artificial components. In an older patient with an osteoarthritic knee, usually those surfaces are resurfaced using prosthetic components, basically metal and plastic surfaces. Sometimes we use biological components where we stimulate cartilage to heal or do cartilage and bone transplants to resurface a particular part of the joint. The surgery involves an open exposure, an incision, to expose the part of the joint that is damaged, and then to replace that component or part of the knee with a specific design component designed for that patient. In this situation, the component will then fit the patient correctly, and it will replace or resurface only that part of the knee that has been damaged. Number one, the components are designed specifically for the patient, so they fit not only the patient's bone exactly, but the design and shape of those components is created to replicate the anatomy of the patient. So rather than using a component which is a generic design, we have tried to advance to using a patient-specific design to meet the unique anatomic needs of the patient. Number two, it's designed to the degree possible to retain the patient's own ligaments. And then the third difference, one bone sparing, two ligament preserving, is the design specific area. We preserve bone substantially. Therefore, in the future, if indeed your knee replacement does eventually wear out, the options for the surgeon will be much greater because the bone has been preserved. Our expectation is that the patient will hurt less and will recover faster. We also expect that they are likely to regain their motion faster because the design is patient-specific. I like to emphasize that in considering replacing your knee, that I'm treating pain, not x-rays. It has a certain degree of risk associated with it, and so the symptoms, the disability, the pain, the suffering, all of the reasons that bring you to the doctor in the first place must be sufficient to warrant the risk associated with a procedure.